A very good evening, everyone. This is Dr. Singaram. Welcome to the topic of week discussion. Today is the second topic I have taken up, which is cystic fibrosis. Please remember, cystic fibrosis is a multi-system disorder which should be known by every medical student to know about the different types of presentation of the disorder and also to know the diagnostic techniques for this particular disorder. With that introduction, let us start the topic of cystic fibrosis. The first important one-liner is cystic fibrosis is the most common life-limiting genetic disorder. It's an inherited disorder, inherited as an autosomal recessive disorder. You all know that. Fortunately, it is not very common in our population, but it is more common in the Western population, especially in the Caucasian populations. And books go on to describe that in United Kingdom, it is one of the most important single gene disorders. What is the problem in cystic fibrosis? It is due to mutation in CFTR gene. What is this CFTR? CFTR is cystic fibrosis transmembrane regulator gene. I am sure that some of you must be knowing where is this gene located. It is located on the chromosome number 7, long arm of the chromosome number 7. Okay, and what is this CFTR gene going to code for? It is going to code for CFTR, which is actually a chloride channel. That's an important point for you to remember. It's a chloride channel, and this defect is what is going to result in manifestations of cystic fibrosis. Now, coming to the CFTR gene mutation, there are around 1600 to 1800 mutations known. But if the question is, which is the most common mutation, please answer as delta F508 mutation. Okay, this is the most common mutation. And what is the problem occurring? What is a biochemical change occurring due to this delta F508 mutation is there is deletion of phenylalanine. These are all the one-liners which you can expect in this basic information about cystic fibrosis. Now let us move on to the pathophysiology of cystic fibrosis. Cystic fibrosis, if you look at the textbooks, they are also described as mucoviscidosis. Now what is this mucoviscidosis? What is the explanation of this term viscidosis? Viscid means something which is thick. Muco means mucus. So it basically means thick mucus. Okay, it is characterized by thick mucus all over the body, and that is a basic problem in case of cystic fibrosis. Let us try to understand why there is thick mucus in cystic fibrosis. If you look at the left side of the picture, it is the normal functioning of this protein, which is the chloride channel. What is that? CFTR. It's a normal CFTR I have put up. Now this is a chloride channel, right? I have told you in the beginning. So what happens if you see this blue colored dots? Okay, they are the chloride ions. So what does the CFTR do? It moves to the membrane. See, this is the membrane of the cell. From the inside of the cell, the chloride ion moves into the lumen. Say for example, lumen of the respiratory tract. What is the purpose of this chloride moving into the lumen of the respiratory tract? In the respiratory tract, that is inside the lumen of the respiratory tract, this chloride is going to make the mucus thin. It is going to make the mucus thin. Or in other words, it is going to liquefy the mucus. What is the advantage if the mucus is very thin? Obviously, if it is a thin mucus, it is going to be easily expelled out by the mucociliary clearance mechanism. This is what is happening normally. Now look at the other side. This is what is happening in cystic fibrosis. What happens? This CFTR channel is not working. So what is going to happen to this chloride ions or the blue dots? They are remaining inside the cell only. Obviously, they are not going into the lumen. They are remaining intracellularly. So what is the effect on the mucus? The mucus will not get liquefied. Instead, it will remain like a sticky or a thick mucus. Now, what is the problem of this thick mucus? One is that it cannot be easily expelled outside. Second is that it easily predisposes to respiratory infections. Are you able to understand this? So, this is the basic problem or the pathophysiology of cystic fibrosis. In the beginning itself, I have told you that cystic fibrosis is a multi-system disorder, but the two most important systems which are affected are respiratory and gastrointestinal. Now, if they ask you the question, which is a system to get early involved in case of cystic fibrosis, most of the students make a mistake thinking that it is a respiratory involvement which is early. But on the contrary, it is a gastrointestinal system involvement which is early. Because most of the times, okay, whenever we come across cystic fibrosis, we always study in relation to recurrent respiratory infections, right? So that is why most of the students answer as respiratory problem is common and early. No, it is not so. Gastrointestinal problems are the early manifestations of cystic fibrosis. So now let us look into the details of what are the gastrointestinal manifestations of cystic fibrosis. You have to remember the term mucoviscidosis or thick mucus. Basically, you can remember in the simple terms like thick secretions, okay? Thick secretions all over the body. Now, if we talk about the intestinal tract in a newborn baby, what is the secretion of the intestinal tract in the newborn? It is a meconium. So what happens? The meconium becomes very, very thick, obviously. And what happens if the meconium is thick? It will get blocked inside the intestine itself. And the place where it is going to get blocked is the ileum, terminal part of the ileum. And this is what we call it as meconium ileus. So what happens? Meconium becomes thick and blocks the terminal ileum of the gastrointestinal tract. So it is actually a form of intestinal obstruction occurring at the level of distal ileum. Are you able to follow this? Now please note that this is not going to affect all the newborn babies with cystic fibrosis. It is seen only in 10 to 20% of cases, but why you should know it is because this meconium ileus is supposed to be a very, very characteristic manifestation of cystic fibrosis. It's a very characteristic feature of cystic fibrosis. Okay, right. So what do you think would be the presentation of a child with meconium ileus? Obvious thing which comes to your mind is that the child will not pass meconium after birth. Normally, a child is expected, a baby is expected to pass meconium by 24 to 48 hours after birth, but this baby with meconium illness will not pass, okay, obviously. And as a feature of intestinal obstruction, the baby also has abdominal distension. What is the other feature? The baby can also present with repeated episodes of vomiting. These are the characteristic clinical features of meconium ileus. And if you take the X-ray, as in a case of abdominal distension, you will find dilated bowel loops. Okay, you will find dilated bowel loops, right? Obviously, as you can see in the picture. And one more thing is that in the terminal part of the ileum, that is in this area, you can notice a ground glass appearance. Okay, that is also very characteristic, ground glass appearance. Okay, so two features, one is a dilated bowel loop, second is a ground glass appearance, which are the X-ray manifestations of meconium ileus. Right. Now in an older child, how do the child present with? The child can present with constipation, right? It is something equivalent to that of the meconium ileus in a newborn. In an older child, the presentation is with constipation. Okay, right. Now what are the other gastrointestinal features? The child can present with exocrine pancreas insufficiency, pancreatic insufficiency. Okay. Now what is the role of this exocrine part of the pancreas? It's in the, yes, fat and fat soluble vitamin absorption. So that is why the manifestation would be fat malabsorption, what we call it as steatorrhea. And what is the other one? It is deficiency of vitamins. Which vitamins? Fat soluble vitamins, namely vitamin A, D, E and K. These are the problems which can be encountered due to this exocrine pancreas insufficiency. Okay, right. Now, previously it was supposed to be very common, but nowadays it is not a common feature, but still you need to know about one more manifestation of cystic fibrosis is rectal prolapse. Okay, these are the gastrointestinal manifestations of cystic fibrosis which you need to know about. Now moving on to the very important, that is the respiratory tract manifestations. I have told you they are not early manifestations. They are not early manifestation. Early manifestation is always gastrointestinal manifestation. Anyway, what is the respiratory tract problem in case of cystic fibrosis? Please remember, it is recurrent infections. It is recurrent infection. Now, in infancy or less than 2 years, what is a common type of infection you get? It is bronchiolitis. It is bronchiolitis, right? Now, after 2 years, pneumonia becomes common. Okay, so less than 2 years, it is bronchiolitis, and more than 2 years, it is pneumonia. Now, they ask this very common question. If a child with cystic fibrosis having recurrent respiratory infection, which is the commonest organism causing pneumonia in that particular child, the answer is going to be Staphylococcus aureus. Okay, some of your references or other guidebooks can give wrongly a Pseudomonas, but no. In pediatric population, Staphylococcus aureus is the most common. Second most common is only Pseudomonas. Please remember, as the age advances, the colonization by the Pseudomonas increases. That means what? In a young child or generally in the pediatric population, it is the Staphylococcus aureus which is more common. Whereas if you talk about adolescents or adults, it is a pseudomonas which is common, and this point has to be remembered, okay, very correctly, right? Now, talking about pseudomonas infection, okay, now one of the special characteristic of pseudomonas in cystic fibrosis is that pseudomonas undergo something called as mucoid transformation. What is the meaning of this? It generates lot of mucus-like material around its structure. What is the advantage of this? It creates a sort of something called as a biofilm around it. Okay, this mucus production is something what we term as a biofilm formation around the pseudomonas. Now, what is the advantage of this biofilm? Obviously, it gets protected from the antibiotics. So that is why antibiotic resistance is very commonly encountered in pseudomonas, which is colonizing the tract of cystic fibrosis patients. That's what you need to know about. Okay, right. Now, what is the next pathogen I have written? B. cepaceae. What is that? It is Burkholderia capaceae. You might not have studied about this in most of the clinical settings, but in cystic fibrosis, Burkholderia capaceae has got a special mention because once the respiratory tract gets colonized by Burkholderia capaceae, it is associated with mortality or death in patients with cystic fibrosis. That is the importance of knowing this. Again, I am telling you, it is not a common infection, but once it occurs, it is associated with very high risk of mortality in patients with cystic fibrosis, right? So, most of your questions will be around this pneumonia and the organisms causing pneumonia, which you should be very thorough about. Now, one other manifestation in the respiratory tract is nasal polyposis. In fact, it's a classical teaching in ENT. They say that bilateral nasal polyps in an adolescent or an older child is very suggestive of cystic fibrosis, and the child should be evaluated in lines of cystic fibrosis. Okay, that also should be remembered. Now, having talked about the gastrointestinal and the respiratory features, now I'm going to tell you about other systems which are going to be involved in cystic fibrosis. When we talk about biliary tract, okay, you can just remember like this: the bile becomes thick and it gets obstructed. Okay, so in the newborn babies, it can actually present with a picture of obstructive jaundice. That is one characteristic feature of cystic fibrosis. Obstructive jaundice can be a presentation, even though it is not very common. Okay, right. Next is, it can also present with cirrhosis, biliary cirrhosis. It can also present with biliary cirrhosis. One more manifestation is because of the thickening of the bile or sledging of the bile. It can also predispose to development of gallstone formation. That's also one more feature in the biliary tract which you need to know about. Okay, right. Now, in the previous slide, we have studied about exocrine pancreatic insufficiency. You should also remember that endocrine part of the pancreas also can become affected. That means what? The insulin production can also become affected. So, what is the patient going to end up with? They can develop diabetes mellitus. So please remember, cystic fibrosis is also one of the predisposing factors for the development of diabetes mellitus. Here they develop diabetes mellitus around second decade. That's what you need to know about. Okay. Next we come to the manifestations in the genitourinary tract. Please remember, in males, all the affected males, almost 98 to 100% of the affected males are infertile. What is the reason that they are infertile? Okay, any idea why it is infertile? Because of the association of cystic fibrosis with bilateral absence of vas deferens. So what is the problem? If the vas deferens does not develop, yes, the patient is going to end up with azoospermia. So that is why infertility is noted in males affected with cystic fibrosis. This is what you need to remember about. In females, it doesn't have much of a problem, but you need to remember that it's not infertility completely, but decreased fertility is noted in females. Decreased chance of fertility is noted in females. Please remember, the sexual functions may be normal, but the question is about fertility. Okay, right? Decreased fertility in females and infertility in males. That's what you need to register in your mind. The last of the manifestation you need to know about is something which involves the sweat gland. Okay, there is not only excessive loss of sweat, but it is also excessive loss of salt or sodium in the sweat. Okay, there is excess loss of sodium as well as chloride in the sweat. Okay, in fact, one of the important diagnostic techniques, okay, in cystic fibrosis is estimation of sweat chloride levels. Okay, what will happen to the sweat chloride level? It will be elevated, right? Because it is getting lost in the sweat. In fact, this clinical feature can be correlated like this. The parents can come and tell you that whenever I am kissing the child feels salty. Okay, the parents can tell you that the child feels salty whenever I kiss the child. Okay, salty child. Okay, that is what is described in textbook. Now they can also ask you one more question. Suppose you do the blood gas analysis of these children with cystic fibrosis. What is the metabolic abnormality you get in cystic fibrosis? This is one more very important one liner which you need to know about. What is happening? There is loss of sodium. There is also loss of chloride, right? So it is hyponatremic, hypochloremic, and also there is also hypokalemic metabolic alkalosis. This is the characteristic metabolic abnormality noted in patients with cystic fibrosis, and this is a very important one liner which you need to know about. So this is the clinical spectrum of cystic fibrosis which we were discussing all this time. As I told you, in the early age, that is 0 to 2 years, which manifestation predominant? It is a gastrointestinal manifestation predominant, where it typically manifests steatorrhea due to fat malabsorption, and because of malabsorption, the baby does not put on weight and height, which is what we call it as failure to thrive. This is common. Okay. Also, I told you about meconium ileus, which is a presenting feature in 10 to 15% of patients. Okay, right. After 2 years, which is going to be common, it is both gastrointestinal as well as the respiratory features. Especially you should not forget about recurrent pneumonias. Okay, right. And after 12 years comes the other system involvement, and it is something like an end stage. Okay, something like a very chronic stage where the patient can develop chronic lung disease in the form of bronchiectasis. They can also go on to develop portal hypertension. They can also develop diabetes mellitus. Now, clubbing is a very important feature which can be noted on physical examination in almost all children with cystic fibrosis once they enter into the adolescent age groups or after 10 to 12 years. Okay, right. So this particular table is a hub of MCQs which you need to know about. At least the ones which I have highlighted should be known very thoroughly. So having known about the features of cystic fibrosis, we now move on to the diagnostic criteria for cystic fibrosis. Now there are two things in this diagnosis. One is when to suspect and next is when to confirm, how to confirm. Okay, right. Remember, when to suspect is presence of typical feature, all the clinical features we are talking about this time, or because the genetic disorder, if you have a sibling affected with the cystic fibrosis, then you can also suspect. And third thing is there is something called as a newborn screening test. Remember, it is not being done in our country, but in the Western population, it is very commonly done. And the name of that newborn screening test is called as IRT. What is this IRT? IRT stands for immunoreactive trypsinogen test. Just know the name of that test alone, no need to go into the details. Okay. If there is a positive newborn screening test, then also you need to suspect. Okay. In the Indian scenario, generally it is with the presence of features, clinical features, or with the presence of cystic fibrosis in the family or the sibling. That's when we suspect, because in India, newborn screening test is not that commonly done. Okay, right. Now, this is only suspicion. How are you going to confirm? Confirm is by means of the lab testing, and as I told you before itself, it is elevated sweat chloride concentration. And here I want you to remember how much elevated is significant. More than 60 milliequivalents per liter. It is very important to know this number, because in your clinical MCQs, they can just give a value of sweat chloride itself and ask you to interpret. So remember which is significant, more than 60. And one more point to be noted, it is not on only one occasion. It is two occasions. It is on two separate occasions. Okay, the sweat chloride should be elevated. Typically, we do it 24 hours apart. So something like today morning and then tomorrow morning. On both the samples, okay, the sweat chloride level should be elevated. Right. Okay. This is one test. Or okay, or identification of cystic fibrosis mutation. Again, here the word is important. What is that? It is not a single cystic fibrosis mutation, but two cystic fibrosis mutation. So identification of one mutation is never going to make your diagnosis of cystic fibrosis. That should be remembered. Okay. And third test is abnormal nasal potential difference measurement. Okay. What you do is, this is called as transepithelial nasal potential difference measurement. But here, point to be noted is, even a single abnormal value is very suggestive of cystic fibrosis. That's what you need to remember. Single abnormal value is sufficient. Okay, right. So please know by heart this diagnostic criteria for cystic fibrosis. One from the suspected criteria and one from the confirmatory criteria is sufficient for diagnosis of cystic fibrosis. Now, sometimes this can be asked as an image-based question in your exam to identify what is a test being done in a child suffering from recurrent respiratory infections or recurrent pneumonia. They can ask you this question. Okay, what are they going to do is something called as pilocarpine iontophoresis. So basically, what are you going to look for? You are going to look for the levels of chloride in the sweat. So first of all, you need to obtain the sweat, right? So how are you going to obtain the sweat? You are going to administer this pilocarpine, okay, to the skin, okay, and this is given to the skin with the help of this electric current. That is why this is called as iontophoresis. Okay, you place some electrodes over that skin, and with the help of this electric current, okay, you actually inject that pilocarpine into the skin, and this pilocarpine will cause sweating, and you can obtain that sweat in the filter paper and you can estimate the levels of sweat chloride. So this is called as pilocarpine iontophoresis, which is the method for detection of sweat chloride levels. That is also important, you need to know about. Now, having known about the features and diagnosis of cystic fibrosis, now it's time for you to know about the management or treatment of a patient with cystic fibrosis, right? Remember, most of the times we are confined only to symptomatic treatment. First is regarding the respiratory care. In that, the first thing to be known is airway clearance. Remember that this patient is having thick mucus, okay, in the respiratory tract, okay. So that is why hydration of this patient is of mighty important, because dehydration will exaggerate the situation, okay. So hydration is very, very important. Good hydration should be maintained throughout. Second is to clear the mucus, okay. You can also go for chest physiotherapy, okay, by positioning and various techniques, okay, you help to clear the mucus from the respiratory tract. Third obvious thinking would be to give a mucolytic, but please remember there is no role of oral mucolytic agents which you have studied in pharmacology. No, there is no role of oral mucolytic agent. What it is going to be? It is going to be inhalational mucolytic agents, okay, right. We have got different options which are available, which are inhalationally given and cause mucolysis. One is N-acetylcysteine, but please remember N-acetylcysteine is associated with a very dangerous side effect of bronchospasm. That is why this is not commonly used. So now, if they ask you the question, which is the commonly used mucolytic for the treatment of this thick mucus in cystic fibrosis, then you have to answer something called as rhDNase. What is this? Recombinant human DNAs, okay, that is what is commonly being given, okay. You can also administer hypertonic saline. So what is the meaning of this hypertonic saline? What is the tonicity of the normal saline? It is 0.9%. So what do I mean by hypertonic saline? It is something more than 0.9. What is commonly used is 3% saline. Hypertonic saline inhalation also can help in clearing the mucus, okay. So this is the airway clearance technique in the respiratory care. Okay, second of course is infections. You have to control the infections with antibiotics. So if a child with a cystic fibrosis is developing infection, what are the common infection which comes to your mind? Most common is staphylococcus followed by pseudomonas, right? Okay, so you have to give an antibiotic which will cover both staphylococcus as well as the pseudomonas spectrum, okay. So what is a common antibiotic which we are going to use? Remember, adequately treated pneumonia is a cornerstone of management, because if you don't treat the pneumonia properly, it can take away the life of the child, okay. So that is why we are going to give, okay, and until the cultures confirm which organism, you are going to give antibiotic which will cover both staphylococcus as well as pseudomonas. What we are using is a combination of ticarcillin clavulanate. Along with that, we are also going to give tobramycin along with aminoglycoside. So these are the antibiotics which you are going to provide empirically in a patient with cystic fibrosis presenting with pneumonia until the cultures have been obtained. Okay, right. Now one more part also I would want you to remember. Can you prevent colonization by these organisms? Prevention of colonization by these organisms is possible for pseudomonas. Okay, you can prevent the colonization by pseudomonas. How do you do that? Obviously, you have to administer something like a prophylactic antibiotic, but here you are going to administer a inhalational antibiotic. Inhalational antibiotic. And this may be one of the very potential questions for your exam. What is the inhalational antibiotic to prevent or decrease the risk of Pseudomonas colonization in the respiratory tract? Please remember there are two antibiotics which can be given by the inhalation route. This may be something which is new, but it is important for you in the exams. One is tobramycin, second one is colistin. These are the two antibiotics which can be given inhalationally and can prevent the colonization of the respiratory tract by Pseudomonas. Right. Now, third is role of steroid. Okay, it is actually a doubtful role because not all patients are going to respond to it, but it has been found that there is a strong link between the cystic fibrosis and increased incidence of reactive airway disease. So, suppose you see a child with the cystic fibrosis developing recurrent episodes of wheezing, then you may go for this inhalational steroids. Otherwise, generally, not in all cases you are going to give inhalational steroid. Only if there is evidence of reactive airway disease or asthma, you can go for inhalational steroids. Now, regarding the other part of management, which is equally important, is regarding the diet. Please remember, these children, they require a high calorie diet. Very, very important point. Second is salt supplementation, especially in hot climates and all, where there is excess of sweating, there is a loss of more salt or sodium, you have to give additional salt. Okay, right. And you all know that there is a pancreatic insufficiency. So pancreatic enzyme replacement in the form of enterically coated capsules or spherules is what we commonly use for pancreatic enzyme supplement. Just know the name. It's enterically coated. Why it is enterically coated? To prevent the digestion by the hydrochloric acid and other substances. Okay, that's why it is enterically coated. Of course, the final part is very, very important for the exam. Fat soluble vitamin supplementation. Obviously, there is a deficiency of this fat soluble vitamin, so that has to be supplemented. Please note that these fat soluble vitamins have to be given twice the recommended dose. This is what you need to remember. They have to be given twice the recommended dosage. Okay, so what are the fat soluble vitamin A, D, E and K? You give vitamin K as an injection. Vitamin E supplementation not important for your exam, so I'm not going to cover that. But what is important for you to know is vitamin A and vitamin D. How much you are going to give? It is dependent on the age of the child. Less than 6 weeks, 200 international units of vitamin D. 6 weeks to 6 months, 400 international units of vitamin D. More than 6 months, it is 800 international units of vitamin D. Once you have known the vitamin D, vitamin A becomes easy because it is basically 10 times the dose of vitamin D. Okay, so it is something like less than 6 weeks, it is 2000 international units. 6 weeks to 6 months, it is 4000 international units. And more than 6 weeks, it is 8000 international units. So you can remember it simply, and it is very important for you to solve the MCQs related to this topic. So till this time, the management of cystic fibrosis is mainly symptomatic. We cannot give a curative treatment, okay, because it's a multi-system disorder, it's a genetic disorder, so no curative treatment was as such possible. Now here comes the recent advanced topic in this cystic fibrosis, which is what we call it as CFTR modulators. CFTR modulators, okay, they modulate the CFTR gene, causing some modifications in the CFTR chloride channel. Okay, they are of two types. One is called as CFTR potentiator, other one, okay, it is actually hidden, it is CFTR corrector. Okay, the second one is called CFTR corrector. Okay, the names may sound very new to you, but it is important for you to know in the exams. Okay, CFTR potentiator, the name itself says potentiates means what? Okay, it potentiate or increases the action of CFTR. So what happens, instead of CFTR not conducting any chloride channel, it will help to conduct certain amount of chloride channel. That's what it is. It is potentiating the action of CFTR. The name of the drug is called ivacaftor. Okay, right. Second is CFTR corrector. What is the meaning of this corrector? It corrects the basic problem in the CFTR itself, making it fully functional. That is called CFTR corrector. The example of this is lumacaftor. Now please note that the CFTR potentiator and correctors are not recommended for all age groups of children. It is usually recommended for children more than 6 years of age. And not every child with CFTR can get benefited by this CFTR modulators. For example, in ivacaftor, they respond only to specific group of children with cystic fibrosis who are having this special type of mutation called G5 G551D mutation. It is not for the usual delta F508 mutation. It is G551D mutation where they are going to benefit the maximum. Okay, and so many trials have been conducted, and what they have found out is if you can combine both ivacaftor and lumacaftor, then it can be beneficial in the commonest delta F508 mutation cases. Okay, so combination of both potentiator and corrector is going to be helpful in delta F508 mutation. That is what is the information we have as of now. But so many trials are being conducted, and in the future, definitely there may be more drugs coming for the benefit of this cystic fibrosis patient. And please take my word that this CFTR modulators are going to be the game changer in the management of cystic fibrosis in future. So in a nutshell or a summary of cystic fibrosis, it's a life-threatening autosomal recessive disorder. Remember, it's not common in our population but in the Western population, and it's a multi-system disorder predominantly involved are the respiratory and the gastrointestinal tract, which is affected early. Please remember, it is not respiratory but it is gastrointestinal which is affected early in the disease. And typical symptoms will lead you to the diagnosis. Always remember, diagnosis has to be made by a confirmatory test. And the commonest confirmatory test which we do is sweat chloride estimation. Remember, sweat chloride has to be done on 2 separate days. It is not on a single day, or a single test will not determine the diagnosis. It is 2 separate tests which should be more than 60 milliequivalents per liter, right? Okay, then only you can make your diagnosis of cystic fibrosis. And as I told you just before this slide, CFTR modulators hold the key for the future treatment of cystic fibrosis. So that is about the discussion of the cystic fibrosis topic. I have 2 MCQs to discuss. Let us discuss that. This MCQ discussion is based on your recent pattern where they give you the clinical cases and ask you something related to the diagnosis or treatment or the management aspect. That's what I have framed the questions based on. Please see the first question. A child with recurrent pneumonia is being evaluated. Sweat chloride reveals a value of 36 and 42 milliequivalents per liter. What should be done next for a definitive diagnosis? Remember, recurrent pneumonia, they are giving you a clue there itself. It could be a possibility of cystic fibrosis. Then they have again mentioned sweat chloride is 36 and 42. Is it suggestive? No, it should be more than 60. It is not suggestive of cystic fibrosis. Now the question is, among the given options, please choose an option which should be done for a definitive diagnosis of cystic fibrosis. Okay, the question should be like this: definitive diagnosis of cystic fibrosis. Okay, now let us look at the options available. 72-hour fecal fat estimation. It can tell you about steatorrhea, but steatorrhea itself will not be just suggestive of cystic fibrosis, right? So it cannot be the answer. CT chest, of course, it can tell you some changes of pneumonia or bronchiectasis, but by itself is not a diagnostic investigation. Transepithelial nasal potential difference is a possible option which can be diagnostic. Second is DNA analysis for delta F508 mutation. These two are diagnostic possibility, but which one will you choose as the answer? You should choose the answer as option C, which is transepithelial nasal potential difference. Now you can ask me, why did I not choose the option D, last option? Because delta F508 mutation is only a single mutation. Remember, for our diagnosis, single mutation is never enough. You need to have 2 different mutations. So that is why the answer for this question is transepithelial nasal potential difference. Next question, you are explaining the prognosis of a child affected with cystic fibrosis to his parents. Which of the following statement is not true? Okay, it's a false statement regarding the cystic fibrosis. That's the question. Delayed sexual development, yes, usually say like 2 to 3 years, there is a delay in the puberty. Okay, basically because of all the things which I have discussed before in the genitourinary tract. So it's a delay in the sexual development, that is also correct. Majority of males are azoospermic. Please remember, I told you almost always all affected males are infertile because of azoospermia. That's a correct statement. Fertility in less female, that also I mentioned. So what is the answer for this question? Answer is option D. Remember, sexual function is not impaired. It is generally normal in all cases. I emphasize this point. It is not a problem of sexual function. It is a problem of fertility, which is the question in cystic fibrosis. So sexual function generally is normal in cases of cystic fibrosis, but the option is mentioning sexual function is impaired, which is a wrong option. Okay, that's all. Right. So thanks for watching this video. I hope you like this topic of the week discussion. Please share with your friends. If you have any questions, please put it up in the comment section below. Please subscribe to this channel and press the bell icon to get notified of new videos as and when they are posted to this channel. The next discussion will be coming this Friday, and I am planning it as a live discussion. I'm not very sure at this point of time. I am planning the live discussion at 5 p.m. and the topic for discussion would be endocrinology. Okay, I'll be discussing clinical case scenarios from endocrinology. If there is any update, I will put it up in my Facebook and the Telegram group, the links of which are posted in the description below this video. Please join those groups, and if there are any changes in the timing or the dates, I will be informing in that video. So this will be my first live discussion coming this Friday. So I am not very sure about it. So if all things are all right, I will be doing the live discussion at 5 p.m. on this coming Friday, that is day after tomorrow. So I will see you very soon in the next video, and have a good day.